Medical harp. This is not music therapy. Medical harp is something that calms you, decreases agitation. Let me tell you a little bit about a study that we're doing. There's a tool called the Richmond Agitation Score. A +6 on the Richmond Agitation Score is somebody who's on PCP, about to rip your head off. And a -6 is somebody who's essentially in a coma. A 0 is somebody at baseline. In the emergency department, we typically start to medicate patients who have a Richmond Agitation Score of 3. What we're finding is by using medical harp as therapy, we're able to decrease the Richmond Agitation Score on acutely agitated patients without using any pharmacokinetics, any pharmaceuticals whatsoever. So just calling Jan over to help with a little bit of medical harp not only calms me down, calms the staff down, but calms the patient down. And not only that, once the patient stays calm after medical harp, it seems to last as long or break the cycle completely so that medication is not needed at all during that medical intervention. I owe this geriatric emergency department to my mom. She was quite ill, 70-plus-year-old female who absolutely hated going to the emergency department. She hated it so much that she would lie and tell you that she felt better. She would lie because she just wanted to go home. She was afraid of the emergency department. She was afraid of the noise, the commotion, the bright lights, the confusing environment. So I asked her, how can I make the emergency department better? So my mom, some of her friends, helped design what we feel is a state-of-the-art geriatric emergency department. It's made to be more quiet, more comfortable, more relaxed, a friendlier, safer environment. Thanks, Mom. When we look at a geriatric emergency department, many people feel that it's really a physical plan. It's really how the place looks, the mattresses and that type of piece. There's really 10 different parts of a geriatric emergency department. There is the environment of care, so it is the physical space that the patient's being taken care of. But there's also quality initiatives, there's also staffing initiatives and training of the staff and education, coordination of hospital resources, coordination of community resources, patient satisfaction extras, even palliative medicine. There's 10 aspects of care that come together to create a geriatric emergency department. With each one of those, it becomes a better level of care for the senior. Let me mention one thing, though, is the physical plant, because we can develop a universal design, a design that not only works for the frailest in society, but if it works for them, it also works for the most healthy in society. Let me give you a couple examples. One of the best parts about a geriatric emergency department is the bed or the stretcher. What we found is it's more comfortable on a dense foam mattress on the stretcher. That works great for frail seniors, but it also works amazingly well for those of you and I who are healthy. We would much prefer a dense foam mattress rather than a very thin mattress without any support. The lighting's very important. If you walk into a restaurant and you say, boy, I love the ambiance here, it may be because the lights are dimmed and more comfortable and more soothing. So in the geriatric emergency department, we have 7 different lighting configurations at each bed that's decided upon by the patient so that they're most comfortable in the environment. There's a tremendous amount of soundproofing in the ceilings and the walls that make things much more comfortable and less scary for the patient who happens to be in the geriatric ED. And there's also other extras that we put into here, like light therapy and aromatherapy, that I think add to the experience of care. And that's important because my mom would not be afraid in this geriatric emergency department. And my mom would give you a better history and allow you to take better care of her. And you'll see your response to therapy in a well-designed geriatric environment. Get ready, guys. It's coming. The gray tsunami is on its way. Here's what we know about the geriatric population. There's 79 million baby boomers who are going to turn age 65. We also know that those over 65 have increased healthcare needs. We know that they require emergency department visits 7 times more than their younger cohorts. We know that when they come into the emergency department, their length of stay is longer, their percentage of admissions is greater than 40%, that their utilization of resources are many times greater than their younger cohorts. This is a group that is coming our way, and we need to be ready for it. But why are they coming into the emergency department? And it's for a lot of different reasons. It's financial reasons. It's the shrinking pool of geriatricians and primary care physicians. It's the fact that seniors present to the emergency department with complex complaints, and that's on top of subacute and chronic conditions. These subacute and chronic conditions make workups very complex and very difficult. And in the emergency department, we become one-stop shopping. We're the place where we can package a senior. Now, that sounds kind of funny, but you emergency physicians out there know that we package patients better than any other specialty. We can take somebody who comes in with abdominal pain and constipation, work them up, find out they have a bowel obstruction, a carcinoma. We can do all that in hours, when as an outpatient that would take 6 weeks to accomplish such a feat. First of all, our geriatric emergency department has a patient liaison. Their responsibility is, one, to see the patient every 20 to 30 minutes to make sure that we're meeting the patient's needs. That if they want some tea, or they want a snack, or they need a blanket or a pillow, that these are supplied to them. Now, why is patient satisfaction important? Because one, the government says so, and number two, it's important for our patients to receive the best quality care. Number two is we have a holistic approach to our medicine that we provide our seniors. We have a pranic healer who helps patients feel more comfortable dealing with particularly pain and other problems that are similar, that are common to an emergency department visit. We have a harpist. The harpist actually explained to me why their therapy works. And actually the harp music fills in the space between the sound of a busy emergency department. We also have aromatherapy, and I think that my staff enjoys the aromatherapy much more than even the patient. So the third aspect of patient satisfaction that's so critically important is communication, and communication with their loved ones. To my amazement, the geriatric emergency department has a list of amenities that are offered to a patient. We offer TV, we offer food and snacks, we offer blankets. But the number one most important amenity that patients wanted was the ability to call their loved one. So we put in wireless phones so that every patient has the ability to call their family to let them know that they're here in the emergency department. But because of some of these amenities and because of some of the care that we give our senior patients who present to the geriatric emergency department, when we look at our patient satisfaction for the old and the very old, or old population, meaning those 75 and older, 100% of the patients remain completely satisfied and give us a 5 on all our satisfaction surveys. One of the things we know about seniors is they will complain, they will answer a patient satisfaction study or questionnaire, and if things are not perfect, then they will complain. Medicare right now is paying us for value-based purchasing, and the senior population is key to that value-based purchasing. So keeping your senior population happy is good medical care and is financially good for the hospital. Quality care is an important metric, or at least a goal that you have to have for a geriatric emergency department. And how do you measure quality? How do you know that you're doing good quality? One of our key metrics that we want to look at is our return rate, or recidivism. Patients who return back to the geriatric emergency department after 72 or 30 days after they were seen. And we focused on 4 different initiatives. One of the initiatives was drug-drug interactions. We wanted to make sure anybody who was on 5 medications or more had their medications reviewed by a pharmacist or by a computer program to identify that there were no drug-drug interactions. Number 2, we have a 2-step emergency department. Step 1 is seeing the patient in the emergency department. Step 2 is actually calling that patient up and following up with the second part of the visit. That second visit, that callback to the patient actually assures that the patient understands their instruction, that they are going to accomplish their transition to care back to their family doctor, and that they understand their medications and how to take them. The third part of our initiative is actually coordinating community resources. If the patient is unable to get appropriate food, low salt foods and appropriate ideas like that, we can go ahead and give them a home health aid. We can provide them possibly with Meals on Wheels or other resources to provide them what they need to stay healthy in spite of their illness or their injury. And the fourth part is coordinating hospital resources, making sure that physical therapy and balance testing and everything that's in the hospital is also available for post-discharge testing from the emergency department. What we found is that our return rate had dropped from double digits, actually close to 20%, down to less than 2% on a consistent basis. Quality of care is the true goal of a geriatric emergency department. All the amenities, all the extras just add to the environment of care and allow the patient to get a better experience. That translates into a better history, a better physical assessment, a better treatment, and response to treatment assessments. So how do you develop a geriatric ED? What's the core ingredients? What is important that you need to know to develop a geriatric emergency department? Let's assume you don't have millions of dollars to spend, that your administration is struggling with all healthcare reform and other pieces. Let me give you 3 ideas that you can use, take home today, and have a better environment of care for your patients. First of all is education. There is a lot of good nursing education and physician education that's now available for geriatric emergency departments. It's important that we learn that we master that. It is our specialty. Let's take control of it. Number 2, I want you to get a piece of paper and a pen, and I want you to write down 2 things. On the first piece of paper, put down the heading, Hospital Resources. And what I want you to do is I want you to make a list of every hospital resource that's available, whether it's physical therapy, whether it's speech and swallowing, whether it's social worker and case managers. Make that list. And then I want you to have a meeting with everybody who you put on that list and say, we're putting together a geriatric emergency department. How are you going to help service that group of patients? How are you going to help in the geriatric emergency department? Now, I told you 2 pieces of paper. On the second one, I want you to write community resources. Now, get together with some of your smart social workers, put together a list of all the community resources that are available. Everything from hospice to Meals on Wheels to SNF units to home health aides. Make that list. Now, here's the expensive part. You have to buy them all lunch. Bring in each one of those agencies, each one of those people who lead that agency, buy them lunch, and then say to them, how can you better service the patients who are coming into the geriatric emergency department? All in all, this is a very inexpensive way, but at the end of the day, you're going to have better service to the senior population that we serve. The silver tsunami is coming to an emergency department near you. I suspect it'll be at your emergency department real soon, if it hasn't already.